Hi guys, I'm just going to make a short video to finish the reproductive system and post it for you guys. Okay, so I think where we were in most classes where we just did the path of the Ductus Deferens or the Vas deferens, how it, let me make this a little bigger, how it goes up from the epididymis and wraps around, sort of goes by the ureter, and then ends in this wide portion called the ampulla, which is sort of on the posterior side of the urinary bladder. Um, it has the entire ductus deferens has a thick muscular layer which contracts during ejaculation. And in one class, but not the other, we got to talk about vasectomy. What a vasectomy is when they usually go right near the inguinal canal and cut a section out of the vas deferens, and they either cauterize it or tie it or sew each section, so that what will end up happening is, we'll see once we look at the components of semen, is that the male will still produce semen, but it won't have any sperm in it. So we'll see how that works. Okay, so when the seminal vesicle and the vas deferens come together right back here, they both sort of join into the ejaculatory duct, which you see right here, and the ejaculatory duct joins with the prostatic urethra. And then let's just go through the other portions of the urethra. We went through them in the urinary system too. So we've got prostatic, membranous, and then penile or spongy urethra. Okay, so briefly, what is the spermatic cord? The spermatic cord is this cord that is encircled by connective tissue, and all the tubes come and go through the inguinal canal to the testes. And what it has in it is blood vessels, primarily the testicular artery and vein, and then nerves and the ductus deferens. And the real reason males are more likely to have inguinal hernias than females is because through the process of the testes dropping through the inguinal canal, it makes the inguinal ring bigger. And it's more likely when a male is like putting a whole bunch of pressure on the abdominal muscles to push a little bit of usually mesentery or something out the hole. Okay, so that's the spermatic cord. Now let's look at the structure of the penis. Okay, if you look at the structure of a penis from, let's see, where is that figure? From this section, you can sort of see that it is not all external. The crura, which is plural for crus, of the penis are behind the body wall, and they're sort of wedged behind the pubic symphysis. And notice that the bulb of the penis is continuous with the corpus spongiosum as well. So I'll show you in a minute how an erection occurs, but you can see that if this was filled or engorged with blood, basically it would make it stand up. So I'll tell you how that works. Okay, so the basic structure of the penis are this portion right back behind the body wall would be the root of the penis, and then the shaft of the penis is relatively obvious, right? This is the shaft, this is the root, and this is the glands of the penis. And so let's briefly talk about circumcision and the prepuce or foreskin. The glands of the penis in an intact male has a prepuce or foreskin covering it. In the US, circumcision is still relatively common, although it's becoming less so. And with a circumcision, what they do shortly after a baby boy is born, usually, is they would take and remove the skin. Sometimes they do it by putting some kind of pressure treatment on it so that it eventually falls off. Sometimes they do it with surgically removing it. So about 60% of US males are circumcised. It's getting less common now. There's a lot of debate about circumcision. For instance, is it medically necessary? It doesn't seem to be medically necessary, although I'm not saying that there isn't any medical benefit. There is one that is still in the literature. It is very likely, and anecdotal evidence from men who have been circumcised in adulthood it is very likely that since it is homologous to the glans clitoris in the females, if you remove the prepuce before a male becomes sexually active, and you've got all this sensory tissue that is sort of being stimulated long before a male becomes sexually active, then it seems to reduce sensitivity relatively dramatically. And that is sort of confirmed with the anecdotal, I mean, you can only an adult male who had felt it both ways would be able to tell us. And of course, that's all anecdotal information, but they do report a dramatic reduction in sensitivity after circumcision, not immediately after, but after a while. Now, so it's been done culturally for quite a while. It's got deep Judeo-Christian roots and also some other cultures as well. So what are the potential benefits? Originally, it was a cultural sort of cleanliness practice. And then later on, it was sort of introduced into the medical literature. And now the American Association of Pediatrics does not recommend circumcision. It doesn't seem to reduce urinary tract infections or STDs in males, except that when males are uncircumcised and exposed to HIV versus circumcised and not exposed to HIV, they're less likely to contract HIV. So that's what the literature says currently, which was just a couple months ago that I read it. Okay, so let's look at the internal anatomy of the penis, the specialized blood vessels, and then we'll talk about how erections occur. So basically, the penile urethra is immediately, of course, surrounded by one layer of erectile tissue. What it really is this big spongy mass of blood vessels that can increase blood flow to the blood vessels while you decrease blood flow out. So if we look in cross-section, we'll see paired corpora cavernosa and then a corpus spongiosum. Each of the corpora cavernosa have a central artery. The artery in the corpus spongiosum you can't see in this figure. Okay, so what is going to happen is when you have greater arterial flow in than venous drainage from, then you are going to increase the amount of blood that is actually in the penis dramatically by about 6 times what it is when a male isn't erect. The limit to the size of expansion is because you have this structure right here, which is the tunica albuginea, and it's connective tissue and it's not stretchy. So when you reach the limits of the size of the tunica albuginea, that's the limit of the size of the erect penis. The blood vessels to the penis come from the internal and a little bit from the external iliac arteries. The autonomic innervation is from the pudendal nerve, and there's lots of sensory nerves, and most of everything runs along this dorsal midline. Artery, veins, nerves. Okay, so we'll come back to erections when we start talking about the sexual response. Okay, so last but not least is the accessory glands for the male. We've already sort of talked about them, but I just want to tell you a little bit about what each adds to the components of semen. Okay, so first is our seminal vesicles. Oh, I forgot to show you something funny. So this is histology cross-section of the penis, which looks remarkably like Kanye West, yes? Okay, so seminal vesicles, right? Prostate gland, bulbourethral gland, and the testes. Those 4 add the components to the semen. So, of course, the testes are going to add the sperm, right? And then what comes from the seminal vesicles, what comes from the prostate, and what comes from the bulbourethral or calcareous glands. So, okay, the seminal vesicles, these guys right here, or on a mid-sagittal section, these guys right here, the seminal vesicles add, they have smooth muscle in their wall and they're lined by secretory epithelium. They've got connective tissue on their wall as well. Those little guys make up about 60% of the fluid volume of semen, and primarily what they have in them is fructose and nutrients that sperm need. Also prostaglandins, and the prostaglandins, they've figured out just recently, actually cause dilation of the cervix, which will increase the likelihood that the sperm can swim into the uterus and then into the oviducts. They also, the seminal vesicles have immunosuppressant chemicals to protect the sperm against the hostile vaginal vault. And they have enzymes in them that the sperm need. And they also have a yellow pigment that fluoresces under UV light, which is kind of interesting because when I was working in the forensics lab, every once in a while we would have someone bring in, for instance, a pair of underwear and say, I need you to see if there's semen on these underwear. And I would charge them $250 and pretty much shine a UV light on it and say, yeah, there's semen on that. And then they would ask if it was their semen. And I would say, well, I need a sample from you, and it's another $750. So yes, it fluoresces under UV light, the components that come from the seminal vesicles. So what comes from the prostate gland? Prostate gland is here or here, okay? And it also has smooth muscle in the wall. It has secretory cells. It's, remember, just inferior to the bladder, wrapping around the urethra. It's got a fibrous capsule around it as well. It makes about 1/3 of the volume of semen. So notice that before we even put in any sperm, we have about 90-ish and above % of the volume of semen. So the prostatic fluid is what makes the semen cloudy. It's got citric acid for sperm. It's got antibiotic chemicals in it that combat urinary tract infections in males. It's got enzymes that enhance sperm motility and enzymes that cause the semen to liquefy until it hits the vagina and then clot in the vagina so that the semen doesn't go past the vagina, just the sperm does. And it also has PSA, which is prostate-specific antigen. And prostate-specific antigen, they can use that to see it have an indication of maybe whether you have prostate cancer, although it's produced in different levels with normal, healthy prostate. And that's also the one that I will talk about again when we get to talking about female ejaculation. Okay, so what the issue is with prostate infections and prostatitis is that if a male has an inflamed prostate, it's usually going to cause problems with urination because it's actually around the urethra. And so prostate exam would actually usually be going up the rectum to feel whether the prostate was actually inflamed. Usually males start getting that exam around age 40. And prostate cancer is not super uncommon. So an inflamed prostate is something that a male needs to take care of and check out and make sure it's not cancerous. Okay. We already met the bulbourethral glands because they actually secrete their pre-ejaculate during arousal, but it will end up in the semen. Okay, so bulbourethral or Cowper's glands, and you know where they are. They're in that, they're like right here near the skeletal muscle, the pupococcygeal muscles. And they produce a lubricating mucus during sexual excitation, and it cleanses and neutralizes the urethra. And that's what I was telling you guys before, that very often with the withdrawal mechanism, it's not particularly effective for a lot of reasons, but for one of them, if the urethra still had sperm in it, it will actually come out with the bulbourethral fluid, the pre-ejaculate. So the method that we were talking about, the withdrawal method, is really not particularly effective. Okay, so I changed this, and I will re-upload these notes for those of you who are interested. This, for instance, might be on a bonus question. Your textbook doesn't have the stages of the female sexual response. It's got the stages of the male sexual response for no reason I've ever been able to determine, because we actually do know quite a bit of this. The female is not quite as well understood as the male sexual response. It's not in your textbook. So what I did in this last part of the notes is, instead of just presenting the male the way that I did before, because it was the way that the text did it, I did a comparison contrast so that we can see what's true in both sexes and then what's true in the female only and in the male only. All right, so we have multiple stages of the sexual response. We have the arousal and plateau stages. We have the climax stage. We have the refractory period and the resolution stage. And then last thing before I'm done is we'll talk about impotence or erectile dysfunction. All right, so let's just talk a little bit about what's going on with the arousal and plateau stages. So physically, the changes when a male or female becomes aroused is that in both sexes, the nipples become erect. You get the sex flush, which increases the blood flow to your face and makes your cheeks kind of pink, and increases blood flow to your lips and makes them swell a little bit. increases your heart rate, increase your blood pressure, increase your muscle tone, and you can start to hyperventilate, which just means you're going to breathe really quickly. It doesn't mean you're going to actually hyperventilate and pass out. Okay, so what's different about a female or unique to a female? The female arousal stage is characterized by increased blood flow or vasocongestion to the bulbs of the vestibule and increased blood flow to the labia majora. The glands and the paired corpora cavernosa of the clitoris, which remember go back as the crura, will swell to 2 to 3 times their size. The breasts will swell as well. The lower 1/3 of the vagina constricts, and the uterus, which is generally, let me remind you, when a woman is not aroused, it is tilted forward like this. When she becomes aroused, the uterus tilts back. Okay. Hey.
What?
That is my little boy who decided he needed to come in right that minute. Okay, so it tilts back. So it's basically going from this position to that position. Okay, so the vagina will become reddened and moistened, and the greater vestibular glands, remember those are right here. I don't know why they're not on this picture, but the greater vestibular glands are right there or right here. Remember they're right there, and they open just inferior to the opening of the vagina. And those will lubricate the opening of the vagina. Okay, so what's happening in a male during the arousal and plateau stages? It's characterized by erection, of course. And so basically what an erection is more blood flow into the penis than blood flow out to the penis. It's primarily a parasympathetic nervous system response. So let's look at how it occurs. The arterioles that lead to the erectile bodies of the penis have an increase of blood flow to them, okay? And what happens is all of these are venous spaces. This is arterioles leading in. It's harder to see on this one because they didn't get the arteriole in there. But what happens is if you have more arterial flow in and then the venous spaces are smashed up against this non-stretchy connective tissue, you basically let more blood flow in and then you compress the venous drainage out and then the blood actually gets trapped within the penis. That's how it happens. And when that happens, basically it's going to take these structures and it's going to make them stand up. That's the function. So blood flow will increase about 6 times above normal during a male erection. So this basically progresses until you reach the limits of the tunica albuginea sheath. And the erection will fade when the arterioles will constrict, and then basically you stop putting as much pressure on the venous drainage, and then the penis is drained. So the loss of erection could be either due to decrease in sexual excitement or sympathetic stimulation or something, or ejaculation. So that's the sort of anatomy of erection. Okay, so the other things that happen during the male arousal and plateau stages is, of course, the bulbourethral glands are going to secrete their fluid to cleanse the urethra and lubricate the penis. So just a couple of things. The original parasympathetic impulse that leads to erection in both males and females, but of course it's more noticeable in males, could be any number of things. Conscious thoughts can lead to the arousal stage and erection. REM sleep, nocturnal erections seem to occur pretty frequently per night in a male and probably in a female, but nobody studied it. A spinal reflex, this just means that basically touching the penis can cause an erection. And then the brain can override a spinal reflex. For instance, if the sympathetic nervous system kicks on, what it will do is it will decrease blood flow to these arterioles. So basically, the fight or flight response is inhospitable to erections. Okay, so now the climax stage. The climax stage has a lot of similarity in the stages, especially the brain similarity. Okay, so the climax stage is basically orgasm and or ejaculation. But I know that we think of that as being mostly a genital function, but there's actually a lot of stuff that goes on in the brain as well. So in the climax stage, the sex flush will continue, and you'll have skeletal muscle contraction in the perineum, the skeletal muscle layer in both sexes. Okay, so skeletal muscle contraction will tighten this layer right here. And then in the brain, in both sexes, you're going to have intense pleasurable feelings related to the release of most of your feel-good chemicals, endorphins, which reduce pain, and they also tend to make you feel relatively powerful. Dopamine, which is your reward neurotransmitter, and then oxytocin and vasopressin. These two have been studied recently. They're both released in both sexes, but not in the same proportions. They cause two different kinds of sort of bonding, and so I'll talk to you guys about it, each type of bonding as we go through. Okay, so differences. Differences during the climax stage. In the female, the uterus was tilted backwards, and now when a woman climaxes, the cervix will plunge into the vagina, and it pulls back up, plunge, pull. Although Masters and Johnson disagreed with this. It has been videotaped a couple of times to see that. Assuming that the literature is right that occurs, it probably increases the likelihood that sperm will move from the vagina into the uterus. Involuntary pelvic thrusting happens. And if female ejaculation happens, let's just talk about how it would happen here. If it occurs in the women that it does occur, and it does occur in some, what happens is this epithelial tissue, this glandular tissue here in the skeins or periurethral glands, will secrete fluid into usually the distal end of the urethra and not the vagina, which I'm sure must be very confusing. And it expels a fluid that's similar to prostatic fluid. One of the ways that we know is that it contains PSA and very little urea. And it seems as if women who do have this response say that it's far more likely when you stimulate that Grafenberg spot, that spot that's got a different texture on the anterior wall of the vagina. But that spot doesn't seem to be really very easy to find unless a woman is aroused. Okay, so in the brain, the difference between male and females is that females release a greater proportion of oxytocin than vasopressin. Okay, so let's talk about those chemicals a little bit. Oxytocin is the same chemical that's released during childbirth. And, during 20 seconds of skin-to-skin contact, it tends to make people bond to one another. Females release quite a bit of this. It also seems to be the chemical that is really, really high in monogamous species. I'm not saying that humans are monogamous, but it seems to be really high in monogamous species. And it's much higher in women than it is in men upon orgasm. Okay, so we'll come back to vasopressin in just a second. Okay, so males, of course, the climax stage is characterized by ejaculation. And when ejaculation occurs, pretty much what you have is contraction of the smooth muscle in every single thing that has smooth muscle. Okay, so you've got smooth muscle all the way through here, right? You've got smooth muscle in the walls here. You've got smooth muscle here. And these are going to have already secreted. You're going to have smooth muscle all the way along the urethra until about the distal 1/3, and then you don't any longer. So it causes semen to move into the urethra. And this is a sympathetic nervous system response. And in the brain of males actually release more vasopressin, which, interestingly, vasopressin causes a different kind of bonding. It's more of a territoriality bonding. It increases male-male aggression. It increases territoriality. So males release more vasopressin than oxytocin. Females. This is not for every male and every female. This is just sort of statistically based on what they've actually looked at. It's kind of interesting. Okay, and then the refractory period is the last period, and refractory period is the next period, and then we have a resolution stage. Refractory period is the period of time after a climax that you can't have another one, and it actually doesn't exist in women. Women have no physiological impediment in otherwise healthy women to multiple back-to-back climaxes. In males, it tends to last minutes to hours to days. The refractory period tends to get longer as a male gets older. Okay, and then last is the resolution stage. And the resolution stage is when it's all over, both sexes. The resolution stage is characterized by profound relaxation, when your genital tissues, your heart rate, your blood pressure, your breathing, and your muscle tone return back to normal. There's some other chemicals that are released in the brain during the resolution stage that increase relaxation, like a chemical called GABA. And then in the females, the uterus will drop back into its resting position, their vagina will relax to normal dimensions, and in the male, you'll have a loss of erection. You probably do in a female too, but it hasn't been measured. Okay, and then the very, very last thing is simply impotence, also called erectile dysfunction. I'm just going to put that in there before I actually upload this for you. Okay, so it is the inability to either achieve or maintain an erection. This probably occurs in both sexes, but of course, women can still have intercourse even if they are not erect. And with men, that is very difficult. When I'm talking about erectile dysfunction, I'm talking about in males. So they once thought that it was always psychological, but we have figured out that actually 70% of cases are occurring because of something is wrong physically, and usually it's a cardiovascular problem. If your blood vessels are all clogged up because of arteriosclerosis and you have poor blood flow, very often it impacts the blood flow to the penis as well. And so as far as proportions go, it affects about 2% of men under the age of 35. It affects about 10% of men by age 55. And by about age 75, it affects around 50% of men. Okay, so I will stop this and